Presbymax is a group of techniques that aim to increase the depth of field in the presbyopic eye, creating bilateral multifocality at central, peripheral, transitional, and multifocal with multifocal ablation. Those are the ways to create that multifocality with the excimer laser. I will say how we achieve that with current methods. Advantages of Presbymax is a well-developed technique, well accepted by patients. It does not mutilate the crystalline lens, is minimally invasive. It may even rejuvenate the eye because positive spheric aberration increases with age. With a negative one, we pay the biopter in a rejuvenated way. We know that the laser is welcomed by patients. In the evolution of this Presbymax surgery, we have to consider two periods. The first one, first generation, which was intuitive, and procedures were created based on refractive data only, whilst the more scientific era now has been based on the modification geometrically calculated of the wavefront and the corneal anatomy. So we have two principles, the central and peripheral by LASIK. The first one, there's positive multifocal geometry in the center of the cornea, whereas the second one, the peripheral by LASIK, there's peripheral ablation created that induces a negative spherical aberration, which changes the depth of focus when the rays of light inside in the peripheral corneal part. Those are two different methods which have evolved towards a common method. The main difference lies in the central method. There's a change, a well-calculated change with little ablation of centrally located tissue, whereas the peripheral method requires great ablation, peripheral ablation to achieve modification calculated and much greater of the corneal area, and so it increases the focus with enough magnitude to compensate what it lacks. We kind of work in favor of lenticular optics because the corneal potency to achieve +3, we have to ablate only 2.21 diopters in the cornea. So ablations which are not so important with notches in the cornea, which are 1.25 or 75 diopters, we achieve like with a multifocal lens. So we achieve a yield which is appropriate with a very low ablation, 4-5 microns. We achieve high increases of refraction of the central part of the eye, and there are some advantages and some disadvantages. But advantages are predominant because in a normal eye there's synergy between things, and so the eye will work better from near, and that's synergic with the line of sight. Where before there was convergence meiosis, it requires minimum tissue ablation because we see with the dilated pupil we use the peripheral cornea, which is for long sight. There's normal continence, normal conditions, dominance of light for far, and when there is low light, it's for far, but with low luminosity for near. Minimal induction of eye order aberrations, we calculate some change in the negative sense, so the change in the retinal image will be minimal. We created the Presbymax technique with the Schwinn technique. We've developed 3 levels of Presbymax. Then the initial Presbymax, I will speak, then Presbymax 3.0, and then the hybrid one. It is based on the creation of biaspheric profile in the cornea at central level, which makes a change in the depth of focus with an increase in the multifocal potency coinciding with the visual axis. So So there's 15, we have like a LISA tree, near distance 35-40%, intermediate 15%, far distance 45-50%. So this is a profile which is similar, like one of the best trifocal lenses that are in the market. On the other hand, it's a bilateral procedure, so both eyes are contributing to the central and peripheral vision, and the changes of contrast are modified minimally with the light, because we minimally modified things with that technique. The basic Presbymax consists in inducing that central hyperpositive change, which is synergic with the pupil. So it's a pupil-dependent technique, and so it increases 1.5 dioptries. The central cornea creating a bispherical aberration, or central aberration respecting the peripheral cornea. So there's a light distribution which is identical to a trifocal lens. And in this published paper with 104 eyes, we demonstrated that the technique works equally in myopic, hyperopic eyes, and better for the myopic eyes, those who complain from not enough close near sight, because there's good long-sightedness, and results were better than with hypermetropes. 70% of cases showed a final result of 0.2 logMAR for close and far, so very good result. And in the cumulative study done, we saw that these results were similar to the ones which we obtained, because 70% of the patients had 20-25 without distance correction, and more than J2, 84% logMAR 0.7. This is a paper we published, and we see the distribution of results according to different authors, so homogeneous. So we have very good results reported by several authors, which is very similar, and therefore we have good initial result with Presbymax. But with advanced presbyopia patients, we have to add something more, because this is not enough. And so that's where the hybrid Presbymax appears. In the non-dominant eye, discrete myopization is induced of 0.75 diopters. In that way, better situation is obtained that with simple monovision, there's low disparity of eyes, and the dominant eye is the best. And so this is the distribution of light, of vision at mediate, intermediate, and distance, at a distance. So we try to have approximately an emmetrope result of -0.2 in the dominant eye and -0.7 in the dominant eye to cover those distances. So we have a procedure which is micro-monovision, less than with other techniques such as Presbyo. These are the distance results, 20-32, better than 10%. Well, you see them in the table here and below. As far as near vision, uncorrected vision was you see 92% J2 or better, and also you saw the lower column. And so these are the accumulation of results published until now. And so 42% of patients was logMAR of 0, so for near and the unit for near and far, it variated up to 0.1 in approximately 75%. So we have 80% of patients with binocular vision, they see 0.8 or more. The hybrid Presbymax is very safe, just loss of a line of vision. You have to contemplate that when we contemplate a cornea and the visual axis, which is 25% of patients with a risk of losing one line, whilst the rest didn't gain or remained in general stable. These are results for hyperopia, more variability than with myopia, as I said that before, and these results with other techniques are better than the myopic patients, because we are flattening the peripheral cornea, so the central bispheric profile is more prominent and benefits better. What is our protocol to apply this technique? Patients should be older than 40, and there's no maximum limit of age. Normal corneal aberrometry must be corneal LOB20 must be normal, and operative vision for far must be normal and have a near vision, which allows him to read J2 with an addition of 1.5. This is the ideal patient for the basic press by LASIK, and from then on you have to use the hybrid one. For photography, pupil size must be of at least 3.5 millimeter, and the range of optimal intervention is between +3 and -4 diopters, when astigmatism after 2 diopters, and an addition from those from 1 to 5 to 2 diopters. So the moment entering the study, these must be the conditions, otherwise the vision wouldn't be satisfactory for the patient. As far as Presbymax, and I conclude that saying it's a reliable method to correct early and intermediate presbyopia, and up to 2 diopters of near vision, and there's high satisfaction of the hybrid patient is better, and there's high satisfaction of patients according to results, and there's a wide range of application, more than with other methods described in the market. And there's a novelty, it can be reversed, because thanks to the very stringent platform as a customized ablation method, and so we obtain the Presby reversal software, and so we may reverse changes in the central cornea. So it's applicable to any case, including pseudophakic presbyopic patients, although there's no evidence. I cannot give you data. At a given moment, if the patient sees worse near vision, we can use we can upgrade Presby LASIK and obtaining in the non-dominant eye 0.75 diopters, and so in the non-dominant eye, sorry, and we improve the vision. Thank you very much for your attention.